So what I'm going to do is just to provide a brief background as to what this topic is all about. Then I'm going to break down each of the questions that I had for the research project into the 4 separate categories, look at the various methods individually, and then outline the results for each, then provide an overall summary of the study, and then give you an opportunity to look at some of the strengths and limitations that we found from the study, and lastly talk about some of the future work that we would like to pursue. So with regards to the term antineoplastic drugs, some of you may know as chemotherapeutic drugs or cytotoxic drugs. Hazardous drugs is also a term that's used as well. As you can well imagine, these are primarily used for the treatment of cancer. They've also been used for other purposes as well, some other immunological diseases. These agents are inherently toxic. We're going to talk about some of the toxic effects associated with some of these agents. But for a patient who has cancer, the benefits far outweigh the risks. Having said that, though, if you are a healthcare worker who's providing care for a patient, you can imagine that there are some concerns about possible exposure. These concerns arose as early as the 1970s about some of the risks associated with exposure. And the reason for this is that these drugs act in a non-selective manner. So they don't specifically target cancer cells. They can also target the healthy cells as well, and that's where the issue lies. So with regards to exposure limits, as an occupational hygienist, we're looking at these exposure limits to see whether or not there is a safe level of exposure for individuals who are working with these products. And so upon review of the Ontario Occupational Health and Safety Regulation, there are no exposure limits listed. For the American Conference of Governmental Industrial Hygienists, or ACGIH, this is a body that promotes the threshold limit value, so it's well recognized nationally as well as internationally, and unfortunately they don't have threshold limit values either. And then lastly, for OSHA, which is the Occupational Safety and Health Administration, so that's the governing body in the States, they don't have permissible exposure limits either. So when substances do not have exposure limits associated with it, the general principle of OLARA applies. So this is as low as reasonably achievable. So basically, employers are expected to try to put forward as many possible control measures as they can possibly achieve given their resources and other limitations to try to minimize exposure to workers. In terms of exposure risk, the literature has found that these drugs are associated with mutagenicity, which is damage to genetic material. There's also reproductive toxic effects, primarily miscarriages. And ironically, they're used to treat cancer, but they can be carcinogenic themselves. Okay? And so in order to, before we move forward with the study, what we did was we did some pilot studies in and around the Vancouver area just to get a sense of what was happening at our local sites, because a lot of literature is based in the United States as well as in Europe, but there wasn't much done in Canada, let alone BC at the time. So we did find that there was surface contamination. So basically what that meant was that there's drug residual on various work surfaces. And we also found that workers in the pharmacy department had dermal contamination. And dermal contamination is important because that's considered the main route of exposure to these particular contaminants.
I'm sorry, maybe you said this, but can you say what exposure means? Is it simply on the skin, or can it be inhaled, or what is exposure?
That's a very good question. We're primarily talking about dermal exposure is the prime route of contact. Inhalation has been bandied about as a possible route of exposure, but it's only for primarily for those people who are actually preparing, because you have to open up the vial, it's under pressure, and it may volatilize, but it's generally prepared in a biological safety cabinet, so the risk is perceived to be quite low. Another problem with inhalation is that they can't actually measure right now, at this moment in time, whether or not there is airborne particulates. So that presents challenges, whereas when it comes to dermal contact, we can sample for that. As you'll see later on as well, we're going to, we sampled for urine as well to see what the intake was of these drug products. Okay. So in terms of looking at the literature and getting a sense of what other problems there were, one of the things was that there's unknown dermal contact frequency. So basically what researchers have done in the past was that they sampled what they felt were possibly contaminated. But because the dermal route is considered main route of exposure, they're not sampling surfaces where people make contact. So for instance, they would sample the floors. And so the likelihood of contact of someone touching the floors is very minimal in my perspective. Having said that, you can still spread it if it's on your footwear and then you walk around with it. So it's still an important consideration, but in terms of actually being exposed to it through dermal contact, it's very low. Also, in the literature, only select job categories as well as departments were assessed previously. So what I mean by that is that there's actually a hospital medication system associated with these drug products. So basically what we're saying is that it has to be initially delivered to the site, so either directly to the pharmacy or it goes to the shipping and receiving department. Then we all know it's drug preparation, so a lot of studies have looked at the drug preparation area, and that's generally done in the pharmacy under the biological safety cabinet. But then another part that wasn't examined is transporting it to the ward. So once the drugs are prepared, it somehow has to get to the unit where the drugs are going to be administered to the patients. So very rarely is it adjacent to the drug preparation area. Then there's a drug administration area. So most of the drugs that we looked at were in the intravenous form. So it's in the liquid suspension and it's given to a patient through IV. There's other ways of administering it, but this is the most common way for the drugs that we looked at. And then lastly, you have to dispose of the drug product. So either the drug vial itself or the IV bag where there's going to be some residual on that. Okay. So basically, most of the literature has focused on drug preparation as well as drug administration, and we felt that there were these gaps in these areas that were not looked at. There's also, from our perspective, there was an exposure underestimate. Because of the fact that they only looked at the drug preparation, drug administration area, we felt that there were other workers that were not considered as part of the at-risk profile, and so we felt that their numbers of people at risk is actually an underestimate. So we felt that there were other people involved in the medication system that should have been assessed previously as well. Then the other part of underestimate is that in terms of the urinary drug contamination studies, researchers primarily looked at the parent product, and we felt that was an underestimate because only about 30% of the drug of our interest, which is cyclophosphamide, we'll talk about that later on, only about 30% is unmetabolized. So that means there's about 70% that is metabolized or some sort of byproduct. And if you don't look at that, then you're only getting a very small picture of what's actually found in the body. Then the last thing is that we want to get a sense of what were some of the determinants of contamination or exposure. So what are some of the factors associated with either the workplace or the worker which may lead to exposure? So based on what we found in our pilot study, as well as what we found in literature, we pursued the current study, which I'm going to talk about. So the three research questions that we want to address were, first of all, is antineoplastic drug contamination found on surfaces located throughout the hospital medication system? So I mentioned that it's not just the drug preparation, not just the drug administration. There's other areas like transport as well as receiving that should be considered. And then we want to see whether or not there was surface contamination. After that, we want to see whether or not those healthcare workers that are somehow involved in the hospital medication system, whether or not they're likely at risk of exposure. And then lastly, what are some of the factors that are associated with either surface contamination or occupational exposure? And so this means the dermal contact as well as urinary contamination. So these are our timelines. And there were 4 study objectives. And we had 6 sites within the Vancouver area who participated. So the timelines are down below, starting in June 2009, ending in February 2011. This is just strictly data collection. Obviously, it doesn't include the data analysis and report writing. So the first part is that we wanted to do site observations, and I'll talk about these in more detail in upcoming slides. Then the second objective was to look at surface contamination, and that was for about half a year. And then last part was to look at personal measurements. It's broken down into first the dermal contamination, and then the other part was the urinary contamination. So just for your information regarding the entire study, we did have ethics approval from not only the university, but also all the different hospitals that were participating in the site. We use cyclophosphamide, here known as CP, from now on as the marker drug of exposure. Now there's individuals are exposed to multiple different types of drugs. Unfortunately, you can't analyze for each and every one of them. So we looked at cyclophosphamide for a number of reasons. First of all, it's very commonly administered at the sites that we asked to participate. And then second of all, from a risk assessment perspective, it's a known human carcinogen according to the International Agency for Research in Cancer. So based on those two factors, we decided this would be a good surrogate of exposure. So if we found this present, then we can assume that there might be other drugs present as well. There are a total of 6 facilities in the Greater Vancouver Regional District, and 5 of them were acute care sites, and 1 was a cancer treatment hospital. At the time of the study, none of the sites, all the drugs were prepared in biological safety cabinets. That's the norm now, that's the gold standard. But none of the sites were using closed drug delivery system transfer devices. So these are devices where containment of the drug product is possible so that there's no spread of contamination when you're mixing or administering the drug products. So these are slowly coming into play in and around facilities in America. I don't know how well it's being taken up in Canadian sites at this time. Housekeepers, unfortunately, were not able to participate. We know that they're a known risk cohort. Unfortunately, at the time of the study, they were contracted out to a third party, and that third party declined to participate. So we are missing a group of people that we know are at risk of exposure. We use the gold standard for analysis, which is high-performance liquid chromatography tandem mass spectrometry. And so this is used for practically all other studies that are current. And then in order to identify the determinants, we generate mathematical models. So linear regression is what we use. Okay, so the first objective then is to look at which surfaces were contaminated, and then also determine which job categories might be at risk of exposure. And this is through site observations, as I mentioned when we looked at the timelines. So in order to do this, what we did was that we interviewed key informants, and these were individuals that were department managers, head technicians, the charge nurse, just to get a sense of which departments might have the drug products flow through them, as well as which job categories might contact these drug products. Then we conducted repeated site observations so that we can understand what the hospital medication system was at each site. You can well imagine that based on the design of the hospital, it would vary from site to site. And that's why we had to do repeated site observations so that we could get a better understanding of how the flow of the drugs occurred at each and every single site. Then from there, we identify which sites might be, which surfaces might be contaminated with drug products. So either the drug was packaged and then placed onto a countertop, then we would consider that countertop potentially contaminated after the fact. Okay. Then lastly, we then tallied up the number of job categories which may contact the drugs themselves or contact those surfaces. So a worker who actually prepared or mixed would be considered direct contact. Those individuals who contacted the surface where the drug product was laid on just prior to, they would be considered indirect contact. And then so in order to understand this, we looked at, we generate contact frequency graphs and then tallied the number of job categories. So this is a histogram of the frequency of contact by the stage of the hospital medication system. On your x-axis are all the different surfaces. On your y-axis is the frequency of contact. I'd like to draw your attention first to the right-hand side of the graph. And so what you see here is stage 2 on the bottom right quadrant, and then stage 4 on the top right quadrant. And so this is drug preparation and drug administration. So what's important to note is that every bar represents contact at the surface, and then the height of the bar means the frequency of contact. So what this basically tells you on the right-hand side is, yes, the literature is indeed correct in assuming that the drug preparation and the drug administration areas are high risk, naturally, given the fact that in our observations, we felt that these are areas where there was going to be drug contamination on various surfaces. On the flip side, though, if you look at stage 1, the receiving, as well as stage 3, transport, you can see that there are still some blue bars there, albeit not as great, but there's still blue bars there. And what's important to note is also that some of these blue bars are not found in the other 2 areas. So there's some novel surfaces that were not found in the other areas that are commonly associated with high risk. So then this is sterile door, that's a common one. Then we've got the bin where the drugs are placed. So this is, again, some novel surfaces that were never examined previously in the literature, and we were able to discover this based on the site observations. Then in terms of the job categories, this table lists the stages of the medication system on the left-hand side, and then on the right-hand column, it lists all the different job categories that are associated with that particular stage that may come in contact with the drugs, again, either directly or indirectly. So rather than go through the whole list, what I want to point out are the ones that are circled here: the porter, the unit clerk, the ward aide, the volunteer, the dietitian, and bowel packer. A bowel packer is a job category that's pretty unique probably to the one facility that had it. And basically they were responsible for taking the bulk waste from an area within the hospital and then storing it into a pickup location for a hazardous disposal team to take away. So that's a contracted company. The hazardous disposal company was a contracted company, but the bowel packer was an employee at the hospital. But going back to what I said about the circled job categories, these are unique job categories that were never mentioned in any other literature. So again, we found that this was quite interesting, that these job categories were never factored into the occupational exposure assessments previously. And in terms of the number of job categories, at one site there was up to 11 different job categories that were considered at risk of exposure. So now that we found that there were all these services that were contacted or may have had drug contamination, naturally what you want to do then is to quantify the drug contamination levels. So this is our second objective. So what we did here was we used a chem wipe that was pre-moistened with a solvent, and then we had a 10 by 10 centimeter template. So basically what that is a plastic template where it's a flat surface. We would put it down and then we would wipe within that template surface area. If it was not flat or it was smaller than 100 square centimeters, what we would do would be sample the area most likely contacted. So if it was a pen, a writing instrument, we would sample the entire surface. If it was a cart, we would just sample where the handles were as opposed to the flat surface of the cart where the contact would not be as great. Okay? And then we took dimensions so we could calculate the surface area. We had our analytical method was quite decent in terms of our sensitivity. We got down to the nanogram level of 0.356 nanograms per wipe. In terms of the determinants, what we looked at were various independent variables. We wanted to see whether or not cyclophosphamide was handled prior to sample collection. We also wanted to see whether or not there were spills or leaks of cyclophosphamide prior to. We wanted to see whether or not the surface was clean prior to. And then some of the hospital characteristics were the number of job categories that were responsible for drug transport. And then looking at the attributes of the wipe were something like this: at what stage of the hospital medication system the wipe was collected. So this is another histogram here. We had 438 samples. A small majority was less than the detection limit. You can see that it was skewed on the left-hand side, so relatively low concentrations. But if you look on the graph here with increasing concentration, you can see that there are little blips of contamination with a maximum contamination level reported at 26.1 nanograms per square centimeter. So this is another frequency graph which highlights what the contamination levels were at each stage of the hospital medication system. So on the x-axis, I apologize for the blurriness. I took it from the software and it doesn't translate very well to PowerPoint. So on the x-axis are all the different surfaces that we looked at. And then on the y-axis is the contamination levels in nanograms per square centimeter. And these are all the different stages. So basically every blue bar that you see means that there's contamination. And so what you see here is that every blue box represents reportable levels of contamination. So not looking at the magnitude of it, which is the amount of contamination, what I think is important is the fact that we are finding contamination at every single stage of the hospital medication system. Okay, so that's something that I thought was quite unique in the fact that especially these stages were never examined. Stage 1, stage 3, stage 5 were never examined in other literature, and so that's something that we want to present to the scientific community. So in terms of those factors that were associated with contamination, we found that the stage of the hospital medication system was a factor, and that's not surprising. The drug preparation, drug administration sites did have higher levels of contamination. What was surprising, however, was that those hospitals which had more than one job category responsible for drug transport. So these are individuals that took the drug from the drug preparation area to the drug administration area. There was a positive association. So these could be nurses, these could be porters, these could be the pharmacists themselves. So if there's a facility that had more than one job category responsible for that task, they had higher levels of surface contamination. So the next thing we did was to collect the personal samples. So we've already mentioned that dermal contact is the main route of exposure, and so that's one of the reasons why we collected hand wipe samples. But then for objective number 4, we took the urinary drug contamination levels because of the fact that you have to take this stuff into your body, metabolize, and that's where the health effects occur. So that's one of the reasons why we wanted to collect urine samples. Having said that, it is a bit more invasive than a dermal contamination, but we just wanted to see whether or not there were any associations. So with this, objectives 3 and 4, the personal samples, very similar methods. We recruited people that were part of those job categories that are identified as being at risk of exposure. We wanted 3 representatives per job category per site. So if there were 3 nurses at every site that were considered risk of exposure, then we would collect those 3 nurses, and then we would go on to, let's say, 3 porters, etc. Okay? And we did convenience sampling, so that's very important to know. We did not necessarily ask these workers to make sure that they handled cyclophosphamide before we came to do the sample collection. It was based on convenience sample, based on their shift, and based on the availability of our research team members to go there. So in terms of the dermal sampling, we basically replicated the surface wipe sampling, but only we wiped the front and the back of the worker's hands. So because it's the same analytical method, we had the same limit of detection. Now for the urine samples, as I mentioned to you before, looking strictly at the parent product of cyclophosphamide is a possible underestimate because about 30% is avoided unmetabolized. So there's about 70% that might be metabolite or byproduct or whatever it may be. So then we looked at 3 additional metabolites that were stable, and then we would tally that up to get a sense of the urinary contamination levels for cyclophosphamide. In order to standardize everything, we collected 24-hour urine samples from workers as opposed to a spot sample, just because it takes about, the half-life of CP is about 6 to 9 hours. So now we're getting at a minimum about 4 half-lives of the drug product. So hopefully that we would be able to detect some stuff in that 24-hour period. So in terms of those determinants that we use, or those variables we use to identify determinants, we had an on-site survey, and this included how frequently they contacted cyclophosphamide and how they contacted cyclophosphamide. We asked about their hand washing practices up until the time of the sample collection. We also asked whether or not they wore gloves prior to the sample collection. Then we also gave them a questionnaire, so every individual that participated had to answer questions about demographics, whether or not they have a duty to handle antineoplastic drugs, their level of training, education related to the safe handling of these drug products, and then what were the usual personal protective equipment practices. So whether or not they wore gloves regularly, whether or not they wore gowns, etc. So these are your dermal contamination levels. We had 225 225 samples, some of them are duplicates. 80% were less than limit detection, so that's a good sign. So that's why it's skewed on the left-hand side here. But you can see that we had some outliers with a maximum contamination level of 22.8 nanograms per wipe of cyclophosphamide. So in terms of this table, what I want to show you is basically we stratified by the different job categories that we examined. And then what I want to show you is the maximum column there on the far right. And the LOD is 0.356, and you can see that for every single job category, it exceeded the LOD, the maximum level. And so these are novel job categories we talked about, the unit clerk, these other individuals in the drug administration unit, as well as some of the transport staff, as well as the pharmacy receiver. These are all individuals that were never examined in other literature that we could find. And so that is another contribution that we were able to make to the scientific community. So in terms of which factors associated with increased dermal contamination based on our mathematical models, those people working in acute care had higher levels than those people in the cancer care. Those individuals that have the job title of porter, nurse, or transport or worked in the drug administration unit, but not responsible for drug administration, had higher levels. Female participants had higher levels than males, and this was actually, we looked at another occupational dermal contamination paper, not for cyclophosphamide, but just for occupational dermal exposures in the past, and they looked at the differences between the genders, and females, for whatever reason, have higher levels of contamination in general with regards to other sort of occupational contaminants. And then lastly, those individuals that have a duty to handle antineoplastic drugs obviously have higher contamination levels. Yes?
Hi, did you say that the acute care hospital is higher than you had one cancer care hospital, so it's higher than the cancer care?
Yes. Okay. Now, in terms of the urinary contamination level, so we did have controls here, and just because we wanted to make sure that it was related to occupational exposure, and urine is a very finicky matrix for those who've worked with it. So the urine, the controls are non-hospital controls that were representative of our study population in terms of age and sex. And you can see here that they're all bunched on the left-hand side, relatively low levels of contamination. Now, if you look at our hospital participants then, you can see that they are bunched generally on the left-hand side, but then as the concentration levels increase, you can see that there is scattering of contamination, higher contamination levels. So based on this graph, we believe that participants in the study, these are hospital workers, have opportunities for higher exposure to these antineoplastic drugs. In terms of those determinants that were associated with increased urinary contamination, those individuals that were employed as the pharmacy receiver, pharmacy technician, porter, nurse, or unit clerk had higher levels than other job categories. And similar to the surface contamination, that where a site had more than one job category responsible for drug transport, they were also associated with higher levels of urinary contamination, and again is a positive association. So in terms of overall summary of results, what we did was that we looked at our contamination levels, and then we divided it by whatever exposure limit we could find. I already mentioned earlier on that there are no known legislative exposure limits. These exposure limits are basically found in the literature that are recommended exposure limits. So they're not enforceable in the local legislation, but certainly some gauge of what's considered a appropriate level for workers. So essentially that when you have a concentration divided by exposure limit, you would get a value of 1. So any scatter that you see above that is considered overexposure. Okay, so we'll start with the surfaces, and that only 8 or 2% of our surface samples exceeded this threshold level that was put out by the United States Pharmacopoeia, which is the professional association, and they listed the threshold level of 1 nanogram per square centimeter. However, this is, we don't know whether or not our levels will exceed this following cumulative exposure. And that's possible because of the long environmental stability of some of these drug products. And again, we only did it as a quick wipe. We didn't do it as a cumulative exposure. So we can't say whether or not there's a possibility of more values, more samples exceeding this particular threshold value. In terms of the dermal wipes, none of the samples exceeded this DOEL, which is a dermal occupational exposure limit of 3,360 nanograms per wipe. However, this is based on the daily exposure, and we again did cross-sectional sampling, so we only did it at a point in time. So again, we don't know whether or not it's possible to exceed this particular threshold level. Then lastly, with urine, 10 or 4.5% of urine samples exceeded this, I forgot what NSRL stands for, not safe, I won't even guess, but it's basically a threshold limit of 1,000 nanograms of cyclophosphamide per day. And so based on our average levels in the study, we did a risk assessment calculation, and we found that these levels result in an increased risk of cancer of 1 in 1.89 per million. So what are the summary messages that we want to pass on to individuals that are interested in the study? So these are the stakeholders as well as some of the policymakers that were present at the study. surface contamination was found throughout the entire hospital medication system. Okay. We also believe that occupational exposure potential is possible, given the fact that we found that some novel job categories had thermal contamination, as well as urinary contamination. Overall, the levels are relatively low, so the controls are working, but if you're looking at a LARA, there are, in terms of as low as reasonably achievable, I think there's things that we can do better. Just anecdotally, when people were transporting the drugs from the drug preparation to the drug administration, they weren't wearing gloves for the most part, and that is considered a standard or routine practice when you look at some of the best practices guidelines. Okay? In terms of what we found, this just adds to the list of occupation hazards that are found in hospital settings. You know, we already have ergonomic issues, violence in the workplace, so this is another issue that should be factored into that. In terms of the policy implications, we think it's important to make sure that people are aware of the risk potential throughout the entire hospital medication system, not just focusing on the drug preparation and drug administration side. And because of that, all job categories that are considered at risk, so these are the porters, the unit clerks, the ward aides, they should be trained in safe drug handling. Again, because we noticed that people weren't wearing gloves, we noticed that people just knew that it was considered a chemotherapeutic drug product, but that was pretty much the extent of their knowledge. They weren't familiar with anything above that in terms of how to properly protect themselves. So again, we feel that that should be factored into the training. And then make sure that control measures are implemented at every single stage of the hospital medication system. Okay? So if there's some way of reducing the number of transport job categories, so having dedicated staff for all the departments. You mentioned about the vials. We know that there's surface contamination of vials. That is probably the likely source of the contamination that spreads. But again, in terms of trying to do a study for that, we have to factor in the patient safety stuff. And then lastly, use these closed drug system transfer devices. These have been proven effective in literature on a number of occasions. Of course, there's cost considerations when we're using these products. So in terms of the strengths, we feel that it was one of the positives was that we did look at the entire hospital medication system, and this provided us with some novel information about what surfaces were contaminated as well as which workers were at risk of exposure. We also felt that those surfaces that were sampled were the ones that we know that workers contacted, as opposed to suspected of contacted. So, and we feel that that was an important element. We had a relatively large sample size, especially for an occupational hygiene study. We had a very decent analytical method in terms of the sensitivity. And then we also looked at cyclophosphamide plus its metabolites in urine so that we could get a better idea of the contamination levels in the urine. And then we collected duplicate samples from the workers. In terms of limitations, it's a cross-sectional design, so there's always issues related to how representative it was at the time of sampling. We were only able to examine one analyte. Again, cost considerations. We can look at other drug products, but that's something definitely worth considering. We were not able to get the three representatives per every job category. Some people just declined to participate, and there were only so many workers in that particular job category. In terms of our sampling of staff members, we did not have random sample selection in 2 sites, and that was dictated by the ethics board for that particular hospital, and so there might have been some volunteer bias. We're not quite certain about the wipe recovery from the surfaces or the hands, just because of different surfaces. We knew about stainless steel, but we couldn't gather the recovery from other surfaces. We can't determine exactly how much people handled of the cyclophosphamide. We asked this question, but there were a lot of uncertainties, and some people didn't even know if they were handling cyclophosphamide. These were individuals that, again, don't have that training to know whether or not it was cyclophosphamide that they were handling. And then in terms of the independent variables, they were collected via self-report, so there might be biases associated with that. So in terms of the future studies, what are some things that we'd like to consider is to evaluate the cleaning protocols, just because of the fact that we still found surface contamination, even though people reported that the surface was clean. And so there's an issue associated with that, and we're not the first ones to find that either. Certainly, we would like to consider looking at the health risk associated with this exposure. We did the risk assessment saying that there is an increased risk of cancer, but again, I think it's, well, if we look at this other aspect, it would also strengthen the findings. This is something very important that you mentioned about determining the mechanism of spread. Like I said, right now we know that the vials are contaminated, but to actually do an actual study starting from the vial to the very end of disposal, we have to factor in patient safety risk issues, and so that's something that has to be worked out. And then rather than look at the determinants for the study as a whole, maybe we can get more information if we broke it down by each stage of the hospital medication system or by the job category separately to find some additional determinants that we weren't able to find because we looked at the study as a whole. So time-wise, we're running a little bit of time. So just for your information, if you want to, about the different publications that came out of this particular study, as well as the various presentations that came out of this study, I just want to acknowledge all the people that were participating in the site. Again, this is for my committee, my PhD, so these are my committee members. Everything was analyzed at the lab at UBC. We had a number of research assistants where this study could not have been done without them. We had a number of study supporters. These are the various unions as well as employee agencies in British Columbia. And lastly, this was funded by the WorkSafe BC Research Secretariat. Okay, so if you want more details, those are my contact information, and Linda also has that available as well. So,
Great.
open the floor to questions.